Hello, my name is Amna Dermish, and I'm going to be discussing in this next slide set the difficult IUD insertion, going over evidence for strategies that can be used to overcome insertion challenges. I do have a disclosure. I'm a member of the Speakers Bureau for Merck. I do Nexplanon trainings. Dr. Tristan has no financial disclosures to report. By the end of this slide set, I hope that you'd be able to describe the management of potential challenges and complications that may arise during IUD insertion, as well as discuss the evidence behind use of adjunctive measures to assist IUD insertion. As we now have substantial data documenting the safety and effectiveness of IUDs across almost all populations, we are seeing an increase in popularity of IUDs. And many of these populations can present a challenge to providers during the insertion process, whether it is with an adolescent patient, a multiparous woman, obese women, or others. When we're talking about IUD insertion failure, though, it can be difficult to get a sense of the rates because of the variety of factors that can impact insertion success. Reported rates in the literature vary from less than 1% to as high as 18%. There are multiple factors, like I said, that can affect insertion success, such as patient characteristics of nulliparity, obesity, and variations in anatomy. However, primary among predictors of success is provider experience and training. And so why is it that seasoned providers almost never fail? Well, they take advantage of the information that's presented to them during the bimanual exam to inform the procedure. They use their tenaculum to align the uterine cavity. Experienced providers move fast and know when to keep pushing, but also when to stop. And ultimately, what they do is identify the reason for the challenge in the insertion and target their skill set to overcome that challenge, using adjunctive measures as necessary, such as ultrasound, anesthesia, and dilation. In this next section, we're going to review some of the evidence behind various techniques that have been used to try and ease insertion success, including cervical ripening and analgesics. So we're going to start by going through different modalities and talk about what's been shown to work and what doesn't. So we're going to start with misoprostol. And what is the data behind that? Many studies have been done attempting to determine whether or not misoprostol actually improves ease of insertion or insertion success. This table here displays trials that have been done over the past 10 years, a total of 9 randomized control trials. And while these 2 studies here at the top did show increased provider perceived ease of insertion, an additional 7 well-done randomized control studies showed no improvement in insertion success, perceived ease of insertion, and in 2 studies down at the bottom, the women who received misoprostol actually reported increased pain compared to women who did not receive misoprostol with their IUD insertion. So then you might ask, what if the insertion has already failed? So this is a patient who's had a prior attempt without misoprostol and the insertion was not successful. Is there any benefit to using misoprostol in this case? There has been one randomized control study of 90 women who received misoprostol in 2 doses, 10 and 4 hours before their insertion attempt, and this study did show an increased success rate among the women who received misoprostol, and there was no difference in use of dilators among the 2 groups. So when we consider misoprostol, I think given the 7 well-designed studies with a preponderance of evidence showing no benefit, there is no place for prophylactic misoprostol for IUD insertion attempts, certainly not for the primary attempt. However, in women who have had a prior failed insertion, there is a possible benefit, and the use of misoprostol can be considered on a case-by-case basis. Moving on, let's talk about the use of NSAIDs for IUD insertion attempts. 3 different NSAIDs have been studied: ibuprofen, naproxen, and ketorolac. With ibuprofen, there's been no demonstrated difference in perceived pain by the patient during insertion, but it has been shown to help with pain after insertion. Naproxen does show improved pain scores compared to women who receive a placebo. And with ketorolac, There's no difference in perceived pain except among nulliparous women who did show some benefit. So when thinking about the NSAIDs, for most women, NSAIDs help primarily with pain after, but not during. But you may consider the selective use of naproxen or ketorolac among certain patients. Finally, let's take into consideration lidocaine. Lidocaine has been studied and used in a variety of manners to aid in analgesia with IUD insertions, including paracervical block, intracervical lidocaine, intrauterine instillation of lidocaine, and tenaculum site lidocaine. And we'll look at each of these. With paracervical block, there is actually scant data, although the data we do have shows a trend towards reduced pain during insertion. In studies looking at paracervical block, the differences in pain scores were not statistically significant, though they did show a trend towards reduced pain. Primarily, we see a wide variety in the actual pain scores reported among women, and in general, the studies that have examined use of paracervical block are small, indicating that there's need for further data in this area. If you are using a paracervical block for your IUD insertion, the lidocaine should be injected at the 4 and 8 o'clock positions, where the vagina reflects off the cervix, and go at least a centimeter deep, avoiding the 3 and 9 o'clock positions where the blood vessels lie. Intrauterine lidocaine has been studied as well and has shown no benefit in terms of perceived pain during the IUD insertion. Intracervical gel shows some promise with variable doses studied compared to placebo. 2% gel shows no apparent difference in pain scores. However, with both 4% gel and EMLA into the cervix, patients report improved pain scores compared to women who received a placebo. It is important to note that in these studies, they waited about 5 to 7 minutes after placing the gel prior to beginning the IUD insertion, and that's certainly an important consideration if you're thinking about implementing it into your clinical practice. For tenaculum site lidocaine, that's the injection of 1 to 2 cc's of lidocaine at the tenaculum site. There's a substantial amount of good data supporting benefit from this, and for those of us doing IUD insertions, we know that the placement of the tenaculum is a common source of discomfort early on in the insertion process for patients. So the use of lidocaine here can provide some significant benefit to patients. When thinking about lidocaine safety, it's important that you're injecting into the proper spot, that you draw back to avoid intravascular injection. Side effects are possible, though allergies are very rare. The side effects that patients might experience from lidocaine could include a metallic taste, tinnitus, tingling lips. Seizures are very rare, and these are all unlikely to occur at the dose used for IUD procedures, and particularly if intravenous injection of lidocaine is avoided. So, finally, looking at lidocaine, our conclusion is that perhaps in some patients there is some benefit to using lidocaine to assist with the IUD insertion. Moving on, we're going to talk about some possible post-procedure complications, starting with vasovagal events are a known potential outcome after an IUD insertion. Stimulation of the cervix can precipitate a vagal event, and these occur due to vasodilation and pooling in the periphery. Some risk factors for vagal events are prior episodes, so getting a good history from your patient and to assess for potential risk. Stress can also cause a vagal event, so for a patient who's particularly anxious about the IUD insertion process, they may be at higher risk of having a vagal episode after the procedure. In terms of prophylaxis, anecdotally, many people will say that paracervical block may help with a vagal event. However, there is no good data to support this. In terms of signs and symptoms of vagal events, things you want to keep an eye out for are patient complaints of feeling hot or nauseous, faint. They may have ringing in their ears, tunnel vision are all common complaints of an impending vagal episode. And for management, there's good evidence to support the use of physical counterpressure or isometric activity to stave off an oncoming syncopal event, and that would be asking the patients to clench their fists, squeeze their gluteus muscles, tensing all their muscles in their body, and may provide some benefit in preventing a vagal episode. And we're going to end with a discussion of uterine perforation. And perforation is something that is a known risk factor of IUD insertions. It's a potential outcome that many people are afraid and worried about. It's important to understand that it does happen, but the risk is low. Reported rates are anywhere from 0.3 to 2.6 per 1,000 IUD insertions. And we have good data to identify risk factors for uterine perforation. These risk factors are breastfeeding. Women who are breastfeeding have a relative risk for perforation that's 6.1 compared to non-breastfeeding women. Time since delivery is less than 36 weeks from delivery, have a relative risk of 3.3 compared to women who were greater than that duration from their delivery. And then finally, clinician experience is a risk factor for uterine perforation. Clinicians who had done less than 50 insertions per year compared to clinicians who had greater than 50 insertions per year did have a higher risk of uterine perforation. It's important to note that the use of dilators, anesthesia, and prior C-section were not associated with an increased risk of perforation. When thinking about uterine perforation, again, important to recognize the signs. However, most cases will be found at follow-up, not at the time of the insertion. Primarily, this is determined by absent strings. So if a patient returns to you for an IUD follow-up and strings are not visualized, it is very important to attempt to locate that IUD. Other signs during the insertion process would be a sound depth greater than expected based on bimanual, increasing pain during the insertion or excessive bleeding. If you suspect a perforation, stop what you are doing right away. Ultrasound, if available, can be used to assess the patient. And if you suspect a fundal perforation, it's important to be aware that the risk of visceral or vascular injury is actually quite low, and in these patients they can be observed in clinic with monitoring of vital signs prior to being sent home. However, if you ever suspect a lateral perforation or any vascular injury, it's important to transfer the patient for further evaluation. In summary, the key to a successful insertion is by first identifying the challenges. Anxiety, pain, and difficulty entering the cervical os are the primary challenges. And then pick your tools according to whatever your perceived challenge is, acknowledging that in a single patient you may have multiple. For anxiety, that should be addressed with counseling, setting appropriate expectations, and providing reassurance. For pain, tenaculum site lidocaine has good evidence to support it. Paracervical block may have some benefit in certain patients and should be applied appropriately. And then with cervical os, as reviewed in our prior presentation, the use of os finders or cervical dilators can assist in navigating. And then finally, recognize the signs and symptoms of complications and be prepared to manage these patients accordingly. And that brings the slide set to an end. Thank you very much for your attention.